At the present time, 12 nosologic forms of hemorrhagic fever are known. They are differentiated by the names of areas where they are first revealed. The following fevers are distinguished: tick-borne hemorrhagic fevers, Crimean-Congo hemorrhagic fever, Omsk hemorrhagic fever, Kya-Sanur forest disease, mosquito-borne hemorrhagic fevers, yellow fever, dengue hemorrhagic fever, chikungunya hemorrhagic fever, and Rift Valley fever, contagious zoonotic hemorrhagic fevers, hemorrhagic fever with renal syndrome, Argentinian hemorrhagic fever, Bolivian hemorrhagic fever, Lassa fever, Marburg and Elbel hemorrhagic fevers. Yellow fever. Yellow fever is an acute viral hemorrhagic disease, one of the most dangerous infectious diseases transmitted by infected mosquitoes. Up to 50% of severely affected persons without treatment will die from yellow fever. There are an estimated 200,000 cases of yellow fever, causing 30,000 deaths worldwide each year. The virus is endemic in tropical areas of Africa and Latin America, with a combined population of over 900 million people. The disease is caused by a virus belonging to the family Flaviviridae. Two epidemiologically different types of foci are distinguished: sylvan rainforest and urban. The reservoirs of the virus in the sylvan form are monkeys, possibly rodents, hedgehogs, and other animals. The vectors of transmission in South America are mosquitoes and other insects. In tropic Africa, these are mosquitoes or species Aedes. The sources of infection in urban foci of yellow fever are human patients. The vector is mosquito Aedes. As the virus is inoculated into a human by the bite of an infected mosquito, it multiplies during 3-6 days in the regional lymph nodes, in the cells of mononuclear phagocytic system, and enters the blood to cause viremia. The blood carries the virus to the liver, bone marrow, kidney, spleen, and brain to involve the vascular apparatus and to cause dystrophy and necrosis of their cells. The incubation period lasts 3-6 days. 3 periods are distinguished. The initial hyperemic phase lasts 3-4 days. The onset is acute. The patient develops severe headache, chill, vertigo, lumbar pain, pain in the extremities. The body temperature rapidly rises to 39-40 and higher. Thirst, nausea, and recurrent vomiting with mucus are characteristic. The face, the neck, and upper chest are markedly hyperemic and swollen from the first days of the disease. The scleral and conjunctival vessels are injected. Rapid eyes. The patient complains of insomnia. The pulse rate is 100-130. On the second or third day, the patient condition worsens. He develops cyanosis and then slight jaundice of the skin and visible mucosa. Blood studies reveal hyperbilirubinemia and high transaminase activity. The liver and the spleen are slightly enlarged and tended to palpation. Tachycardia is followed by bradycardia. Epistaxis and gingival bleeding are frequent. Blood is seen in the vomitus, black vomit. Remission begins in 4th-5th days. It lasts from several hours to 1 day. The body temperature drops to normal or subfebrile. The patient condition improves. Vomiting ceases. Pain abates. If the disease runs a mild course, recovery begins with the fall of temperature. In moderately severe and severe cases, the phase of remission is followed by the phase of reaction or venous stasis, toxemia, that lasts 3-4 days. Remission can be absent and the initial period can be followed immediately by the reaction phase. The patient condition rapidly worsens, the temperature rises again and jaundice intensifies. The skin is pallid, hemorrhagic rash, petechia, purpura, ecchymosis develops on the trunk and the extremities. Gingival bleeding, hematemesis, nasal and uterine bleeding leading to miscarriage develop. Arterial pressure falls, oliguria or anuria attended by azotemia develops. Hematologic change, leukopenia, neutropenia, lymphocytopenia, high globulin and color index, and accelerated ESR. Blood coagulation is delayed. The fever period lasts 8-9 days, and then the phase of recovery begins with a slow restoration of the upset function of the organ and tissues. A fulminating form of the disease leads to death in 3-4 days. Yellow fever is diagnosed on the basis of clinical and laboratory findings. Virus is isolated in the laboratory from a blood specimen taken during the first 4 days of the disease. Discovery of antibodies to the virus using the different tests is diagnostically important too. 4-fold increase in the antibody titers in paired serums is diagnostically trustworthy. Serological studies can confirm the diagnosis retrospectively because the antibodies to the virus can be revealed only on the 2nd week of the disease. Treatment. There is no specific treatment for yellow fever, only supportive care to treat dehydration and fever. Associated bacterial infection can be treated with antibiotics. Prevention and control. Vaccination, mosquito control, epidemic preparedness and response. Lassa fever. Lassa fever is an acute viral hemorrhagic fever caused by the Lassa virus and causes 300,000–500,000 cases annually with approximately 5,000 deaths. The infection is endemic in West African countries. Outbreaks of the disease have been observed in Nigeria, Liberia, Sierra Leone, Guinea, and the Central African Republic, but it is believed that human infections also exist in Democratic Republic of the Congo, Mali, and Senegal. The disease is due to Lassa virus of the genus Arenavirus, the family Arenaviridae. Hemorrhagic Lassa fever is a disease with natural nidality in Africa. The source and reservoir of infection is the African multi-mammate rats. Infection is transmitted by person-to-person contacts during pelt processing or hunting in endemic areas, through fomites infected with rodent excretion. Foodstuffs and water infected with rat excrements are an important factor of infection spread. Another source of infection is an infected person who remains contagious during the entire length of the disease. Human-to-human transmission is effected through airborne route, direct contacts, and parenterally. Cases have been reported of the disease among medical personnel because of nosocomial contamination with the blood of the disused or blood-stained medical tools and instruments. Through the portal of entry, the virus passes to tissue or regional lymph nodes, where it multiplies and is then released into the blood that carries it to the liver, kidneys, and myocardium, where in turn it multiplies and causes damage to these organs. Permeability of the vessels is also upset. The virus is released into the environment with droplets of mucus, urine, and feces. The incubation period is from 3 to 17 days, usually 7–8 days. The onset of the disease is mostly insidious. The disease begins with chills, elevation of body temperature, increasing muscular pain, weakness, vertigo, chest and abdominal pain, nausea, vomiting, and diarrhea. The face and neck are edematous, the mouth mucosa is hyperemic and edematous, tremor of the eyelids and exudative pharyngitis develop. Body temperature of 39–40 can persist for 2–4 weeks and fall by lysis. The temperature curve may have two waves. During the advanced stage of the disease, conjunctivitis develops. Ulceration of the lips, cheeks, and fauces is possible. Radial epithelial eruption on the face, the trunk, and the extremities can be seen. Epistaxis can develop. Lymphadenopathy, leukopenia, and thrombocytopenia are characteristic. ESI is high. Petechiae can turn into vast hemorrhage on the skin and mucosa. Subcutaneous hemorrhage on the arms, abdomen, and legs can develop. Blood spitting, hematemesis, menorrhea, intestinal other bleeding, jaundice, and signs of encephalitis can occur. Renal involvement can be manifested by oliguria, albuminuria, and microhematuria. The course of disease is usually severe. The temperature fall is usually attended by septic shock. Following recovery, the patient remains weak for a long time. Increased fatigue, headache, and dyspnea can persist. The diagnosis is based on clinical, epidemiological, and laboratory findings. On the 7th to 10th day, antibodies can be revealed in the patient's blood by the serologic method. Serum, blood plasma, facial washing, saliva, and urine, also specimen of the liver, kidney, and other organs of the death should be examined in the laboratory for the presence of the virus. Treatment. Ribavirin, an antiviral drug, has been used with success in Lassa fever patients. It has been shown to be most effective when given early in the course of the illness. Patients should also receive supportive care consisting of maintenance of appropriate fluid and electrolyte balance, oxygenation, and blood pressure, as well as treatment of any other complicating infection. Prevention and control. These measures include destruction of rats, the main source and reservoir of infection in human dwelling, protection of the houses from penetration of rodents. Rodents should be destroyed in the vicinity of the populated places in endemic areas. Foodstuffs and foods should be protected from contamination with rodent excrements. Potable water should be boiled. Care should be taken when carrying out medical manipulation, taking materials for laboratory studies, and taking care of patients. Ebb and Marburg virus hemorrhagic fevers. Marburg virus causes severe disease in humans and non-human primates in the form of viral hemorrhagic fever. Ebola virus disease is the name for the human disease caused by any of the 4 Ebola viruses. Ebola virus disease is a viral hemorrhagic fever and is clinically nearly indistinguishable from Marburg virus disease. Mortality rates are 50–80% for Ebola virus hemorrhagic fever and 30% for Marburg virus hemorrhagic fever. Sporadic outbreaks have continued since this time, usually in isolated areas of Central Africa. The causative agent of Ebola hemorrhagic fever is Ebola virus, and of Marburg fever, Marburg virus, which was isolated in Federal Republic of Germany. The source of Ebola virus fever are humans. The role of animals as the source of infection has not been established. Humans are infected by human-to-human contacts. Hands soiled with blood or excrement containing blood are an important transmitting factor. Ebola virus can also be transmitted through infected syringes and needles. The source of Marburg hemorrhagic fever are also humans in the period of the disease when the virus circulates in blood and during recovery period. The reservoir of Marburg virus has not been discovered. Complement fixing antibodies were isolated in 36% of cases in the blood of green monkeys in Uganda during serologic studies. The antibodies were also detected in other species: macaque, chimpanzee, orangutan, baboon. Experimentally infected monkeys develop severe illness. They excrete the virus with the saliva and feces. The virus is dissipated with the patient's discharge containing blood. The disease can thus be transmitted by the airborne contact, alimentary, and sexual routes. Pathogenesis. Virus acts directly on the cells of vascular endothelium to upset microcirculation. As a result, necrosis and hemorrhage in the liver, kidney, testes, ovaries, and lymphoid tissue occur. viremia persists for 14-19 days. The incubation period in Ebola virus fever is 2 to 15 days, in Marburg fever from 1 to 9 days. The disease begins acutely with fever, headache, spine and lumbar pain. From the first days, the patient complains of dry mouth, tickling throat and pain in the fauces. Abdominal pain, diarrhea and vomiting develop on the second or third day. On the fifth or sixth day, most patients develop maculopapular rash that persists till the 10th, 14th days of the disease. The hemorrhagic syndrome occurs on the third or fifth day. Petechia and ecchymosis develop, epistaxis, hematemesis, bleeding, erosions in the mucosa of the mouth and gums are seen. Conjunctival injection and hematuria occur. Severe cases are marked by gastrointestinal bleeding. The central nervous system can also be involved. Leukopenia is followed by leukocytosis with neutrophilia shift. The recovery period lasts 1-3 weeks. In fatal cases, the patient dies on the 7th-9th day of the disease from septic shock. The diagnosis is established on the basis of clinical, epidemiologic, and virologic findings. Treatment is primarily suppurative in nature and includes minimizing invasive procedures, balancing fluids and electrolytes to counter dehydration, administration of anticoagulants early in infection to prevent or control disseminated intravascular coagulation, administration of procoagulants late in infections to control hemorrhaging, maintain oxygen levels, pain management, and administration of antibodies or antimycotics to treat secondary infection. Prevention and control, behavior modification, proper personal protective equipment, and sterilization, disinfection.